Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you and mail your contributions to Kingston Community Radio. Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. And good morning, this is Dan Gatis, and this is a fantastic Medical Monday, June 7th, and 66 degrees here in uptown Kingston. And weather and forecast for the next couple of days. Sunny to partly cloudy today with a high of 93, which is a record high for Tuesday, June 7th. And tonight, mostly cloudy with a low of 69. Tuesday, 80% chance of scattered showers. It's Monday, June 7th. And tonight, mostly cloudy. Okay, back on. Okay, now going on toward tomorrow, there is an 80% chance of scattered showers and thunderstorms in the morning, and continuing in the afternoon, a high of 85. Tuesday night, continuing showers and thunderstorms through midnight, and a low of 67. We'll be right in the morning. And continuing in the afternoon, a high of 85.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5 Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York.
And found a zillion of them in the stream from our lookout rock. Then my sister and I escaped from an evil slug king. I went back to my super twin fort for safety. Then we told stories till it got dark, and the Big Dipper led us all the way home.
Where were you, Jill?
We went to the forest. It's not that far away.
Ask your parents to take you and your friends to the forest this week. It's closer than you think. Check out discovertheforest.org. Brought to you by the U.S. Forest Service and the Ad Council.
Has your child swallowed your medicine, your laundry detergent, your nail polish remover? Call the Poison Helpline. Have you inhaled paint thinner, glue, pesticides? Call the Poison Helpline. Have a question about a dose, a fume, something your kid just drank? Call the Poison Helpline. Poisonings can happen at the home, on the job, or in the great outdoors. Call the Poison Helpline first for fast, free advice from medical professionals. Call 1-800-222-1222 anytime, anywhere. 1-800-222-1222. Save the number, save a life. Brought to you by the U.S. Department of Health and Human Services. Free advice from medical professionals. Call 1-800-222-1222.
Hi, this is Anne Marie from the great town of Kingston, and I support Kingston Community Radio, and so should you.
Brought to you by the U.S. Department of Health and Human Services. Free advice from medical professionals. Call 1-800-222-1222.
Hi, this is Anne Marie from the great town of Kingston, and I support Kingston.
And you're listening to KCR, Kingston Community Radio, WGHQ 920 on your AM dial, 92.5 FM, and streaming online at mykcr.org. KCR is talk radio, so please call in. Your number to call in is 331-9255. And fantastic Medical Monday with Dr. Eric Stamberg. Let's get going. Please call in.
All right, a fantastic Medical Monday. All right, well,
yes. I hope everybody's healthy today.
I was going to say, very high expectations for this morning's show. All right, good morning. Welcome to this morning's show. Robin will be joining us, and I hope everybody's good morning to Dan as well. Very high summary in his this morning's show. All right, good morning. Welcome to quite a Hawaiian shirt.
Yeah, it's maybe not a Hawaiian shirt, but a good summer.
Dan as well. Very high summary in his, and 93 degrees. So it's
I think so.
Quite a Hawaiian. Very briefly, just want to remind people how important hydration is. This time of year, people still, maybe getting their yards together or whatever, and you just might underestimate how much the heat is affecting you, particularly if you're older. You're on medications like diuretics, which are commonly referred to as water pills. You have diabetes, where hydration is important. It really comes down to many, many things. So I just want to give everyone that warning and really don't underestimate your body's need for hydration. I don't know how many people are at the boating. We live right in the Hudson River here, but
that can be the worst.
Right.
You You are literally sitting in a desert on a very reflective, sunny deck.
And it's usually a breeze.
You can get sick easy with the sun.
Right.
Yeah.
You don't realize how hot it is because you got this constant breeze.
Yeah, sunny.
You're sitting on a desert. Usually a breeze. Comes back to the water everywhere analogy that we used to describe our healthcare system. You don't realize hot it is a couple weeks ago. Anyway, so we do have a guest this morning after the 8 o'clock hour. His name is Dr. Michael Kortbus. He is a local ear, nose, and throat physician working primarily out of Red Hook. We're going to talk about various ear, nose, and throat subjects, including a new treatment for sleep apnea called the Inspire. It's a really unique device, and I look forward to hearing about this. I want to know what role it has for helping my patients. Sleep apnea is a big deal. We have a lot of people who suffer from it, and the treatment that we, for the most part, have right now, I always describe as draconian. Basically, this CPAP device that someone has to sleep with, and it's kind of also a big deal. You get used to this device. How it might interfere with your romantic life, or just the weirdness of it. That you have to sleep with this device all night long. So I look forward to hearing about that as well as some other general topics. I of course want to ask him about postnasal drip, the bane of existence for many people. Some people might say, even including me, but it's general reasons why you should go to your nose and throat doctor. But until then, we do have some various topics I wanted to touch on. Might say, even including me. And there was a time in the past year where we've spent most of our show talking about COVID and generally. But until then, things have subsided, not gone. I had a couple of cases I diagnosed last week, so it's still out there. And it really comes down to maybe furthering our efforts with vaccination attempts. New York State has a little bit under 50% of its population fully vaccinated at this time. And there was you can see this stuff online because the CDC publishes the data. And it's easy to access. Other states are really below that, and many states are in the mid-30s. I mean, it's really just too low. So how do we fix this?
From the availability.
What's that?
From the availability.
Yeah, it is available. Now we're talking about exporting it. To how do we fix this? Taiwan and other parts of the world that need it. Yeah, I mean, this is one of our themes that Rob and I first started to do the show. We talked about prevention, and we were always in the context of the flu shot, and we're trying to make kind of the public health argument with this guy. It's not even an argument. I mean, it's one of our themes. It's just a statement of kind of fact. That there's something that comes in the realm of public health, the greater good. And for example, tuberculosis screening programs. Whenever people have to get a new job, they got to get a PPD, which is a TB test. I mean, it depends on your job. That's kind of a remnant of a public health program that was meant to identify people with tuberculosis and implement appropriate measures. That's kind of a remnant. Just vaccinations in general. In the pediatric world, things that are just a distant memory that used to be, an important part of medical care. Things like measles, polio, even chickenpox. Kind of a memory. And then that's a good point to discuss chickenpox. But people go, we all had chickenpox. What's the big deal? Well, on a national level, there are about 50 to 100 deaths annually from chickenpox. That's a good point to discuss chickenpox. I get it. Most of us had mild cases. Most of us did fine. On a national level, there are about 50 the idea is to prevent 50 to 100 deaths per year.
Absolutely. And aren't there?
I get it.
Aren't there? Hey, Robin.
Had mild cases. Most of us fine.
Many more diseases that the childhood vaccinations cover. Aren't there?
I was talking to some patients about this last time, and I do have patients and parents in my practice that are not non-vaccinators. They're slow vaccinators. I mean, they're nervous, and I don't think I was talking to some patients about this last. I wouldn't respond to their anxieties in the same way. When I had them, when not non-vaccinated. They're slow vaccinated. But I don't think. I think it's a mistake to not listen to and try to assuage their concerns. I don't think these are like militant non-vaccinated. But I don't think. Anyway, so if you think about it, go back just 30 years to 1990. The standard vaccines for the pediatric world and young adult will be MMR, measles, mumps, rubella, polio, and then the DPP, diphtheria, pertussis, and tetanus. That was kind of it. And then the 90s, things exploded a little bit. You had the hepatitis B vaccine show up, something called the pneumococcal vaccine, or what's called Prevnar for pediatrics, Haemophilus, things that you don't even really hear much about. Vaccine showed up, and the chickenpox vaccine showed up, and something called a rotavirus vaccine showed up, and HPV vaccine. I mean, it really exploded. So some of the anxiety really comes from that kind of deluge. They just rotavirus, it's a lot. So anyway, but at some point, if a kid's going to enroll in public schools, they're going to have to get vaccinated. So some of the anxiety really comes from the list of medical exemptions is very, very short. Anyway, so legitimate medical exemptions, and be glad your kid's not on that list. Kids with certain types of immunodeficiencies, medical exemptions, maybe undergoing cancer chemotherapy treatments. Those are the list of exemptions. And you can have an allergic reaction to a vaccine. You can have an allergic vaccine to anything. You don't know until therapy. You can have allergic. I prescribe medications all day. I mean, people can have any. And you can have an allergic reaction to anything. It's just one of the things we do. That's why it always comes down to risk versus. You don't know until therapy. You can have allergic. I prescribe medications all day. I mean, people can have any. Anyway, so why are we talking about this? Because the vaccine rate. I estimate there's about maybe, at least locally or maybe in my practice, still about 30% of people that are not vaccinated, and I would divide that in half. People who kind of need a nudge and just a little more encouragement, and then people are just really got their heels dug in and they're saying that. But the topic of COVID for younger adults has been the nudge a little bit, and just a little more encouragement. 3 reasons. The vaccine age has kind of gone down, so there's been a movement to get the adolescent population vaccinated as well. That's one reason. The other reason is there have been reports in the news about a possible medical effect of the vaccine called myocarditis, which sounds scary. And third, an article that was in the news last week, a very interesting study, and that's why I'm bringing it up. So the study was published in JAMA, the journal of the AMA, a very reputable journal. And they studied hospitalized children in the U.S. with COVID. So basically, about 12, these are the results of the study. 12% of U.S. children with COVID-19 were hospitalized in 2020. So if someone's hospitalized, they're pretty sick. So that's basically 1 in 10. So any notion that, COVID is kind of mild in kids and they don't need the vaccine, I think 1 out of 10 hospitalization rate is pretty high. It's certainly much higher than the I'd have to produce the numbers, but I suspect it's higher than the flu rate of hospitalization due to influenza. Okay. So of that 12%, about a third of those had severe disease. Now that's interesting because if you're already admitted, I think your disease is severe enough. But the article defines severe disease that required mechanical ventilation or admission to an intensive care unit. So basically 1 in 9 children with COVID needed hospitalization, and about 1 in 28 had severe ventilation. So, I've heard that kind of said, the young people don't die. Basically, 1 in 9. We have over 600,000 deaths. If you look within the data, there are young people amongst those over 600,000 deaths. And here, okay, fine. If that's your criteria, who lives, who dies, we have over 600,000 deaths. There are young people, but amongst those over 600,000 deaths. If that's your criteria, you're not paying attention to other things. How sick someone is, and then this whole topic of potential long-term concerns. So this article, in and of itself, I think makes a good case for vaccinating the younger age people now. At this point, it's still teenagers. So this article, in and of itself, So remember that. So a kid has a 1 in 10 chance of being hospitalized and a 1 in 25 to 30 chance of being severely ill. And then potentially being put on a ventilator because of this. 1 in 10 chance of being hospitalized. So I think that article
also their potential for carrying and spreading.
And then you have the public health argument, and anecdotally, that's happened in my practice too. The rate of diagnosis is much lower, but there have been a few cases in the past week when we diagnosed COVID, and when we kind of talked about where it came from, it seemed to come from the kids brought it home. The rate of diagnosis is much lower. The public health argument is the other diagnosed COVID to get the vaccine. So I will stand by the recommendation that people 12 and up should get the vaccine. Of diagnosis is I was reading about this concern over myocarditis. The myocardium is basically your heart muscle. Myo means muscle, and cardium means heart. And myocarditis is kind of what it sounds like. It's inflammation of the heart muscle. It is frequently viral. Or idiopathic, kind with no obvious cause. Yeah, it can't be serious. Your heart's not. It is, is the muscles invaded and not pumping regularly? It's a concern. So there have been reports in the adolescent population of this as a concern. And most cases seem to be mild and what we call self-limited. So there have been reports in hospitalizations. And I read and I try to make sense of this because I want to try to give the accurate recommendation. I read last night there were some experts. One was an infectious disease specialist from Tufts, certainly a reputable institution. Who was kind of, not quite going, still kind of hedging on what should be done, whereas other experts in the article were really saying the benefit of the vaccine outweighs any theoretical risk. So I would go with that, but you have to understand that this discussion is still going on. It's okay to have this discussion. Other experts in the article were really saying, and that's one caveat though. Whenever you hear something in the news of medical opinion, you always want to know who's giving the opinion. Is the person a doctor? Okay, you don't have to be a doctor. You can be a PhD in immunology, or you could be a person, a nurse practitioner or something. But I sometimes am concerned about immunology. People on TV often that I don't think are qualified. The example I'll give is a channel that I won't mention, but the experts that was offering opinion, which was kind of against specifically this topic, telling young adults that they don't need to get vaccinated. I was a retired surgeon from Pittsburgh. So I don't know what was worse. He was retired, there was a surgeon, or was from Pittsburgh. Specifically, but that's not important. I'm from Pittsburgh. All right, never mind. Let's not insult people from Pittsburgh. Yeah, but he's up there, as an expert. You want to know who's your expert? All right, never mind. Let's not insult people from Pittsburgh. Working with the ex-president. Scott Atlas. He's a doctor, but he's a neuroradiologist. He was the expert. He doesn't know about it. All right, never mind. He talked to the infectious disease doctors and other similar type of specialists. They're pretty much uniform in how they feel about this. Just keep that in mind when you're paying attention to these doctors and experts. Who exactly are they and what made them an expert? Pretty much uniform.
Another big topic is also the masks right now. What do you think about that? I mean, there's a big push for parents are really wanting their kids to not be masked at school. It's too hot. It's too cumbersome. Kids can't breathe. It's basically because it's the hot weather. But their kids to not be masked. What's your opinion?
Again, anecdotally, having some kids in the office, even 3-year-olds, the ones I saw seem to do okay with the mask.
What's your opinion?
So again, I'm not sure the health concerns are valid. I guess a better question is, do we still need the kids to wear the mask? the ones I saw, I always
What's your opinion?
want to defer that to the experts, but I think they would say yes until there's adequate vaccination at a certain level, at which point we can let it, as we with the routine wearing masks, but I think they would say
right, you just mentioned that the one, that COVID case you were just talking about kind of traced back to.
Right. But is it possible some kid has asthma and they just can't wear a mask? Or I've had a few is it possible parents concerned about just kind of behavioral issues in their kid, what they would call sensory issues, and that would be tough for them. By the way, you ever go to a place and you see kids wearing headphones?
All day, every day.
But I didn't mean like listening to music headphones. I meant like kind of like noise.
Noise producing headphones.
I didn't mean like what's the context that a parent would do that to their kid?
Sound, right. Noise producing. Kid needs it.
What's the context that
it's too much noise. It's too loud.
So, in this case, depriving,
too much noise.
Interaction and sensorium, in this case, how is that different than wearing a mask? I just think the kids adapt and sensorium, in this case, how is that different? It's tough to be an enforcer. I don't want a teacher to have to be kind of policing the kids, and I don't want a teacher to have kind of be at odds with the parents of the kids over this issue. One of the things we always said is you may like it or you may not like it, but the regs are the regs. You gotta. One of the things we always said is you may like it or you may not like it, but the regs are the regs. You gotta. Any other points regarding this that you think have come up?
No, that's pretty much. I'm glad about the forthcomingness of the media to talk about like this myocarditis or forthcomingness of the with the media to talk about what happened with the J&J vaccine, where with the media to talk about I don't know what I feel like there's like controversy where people think it's like they're keeping everything hush hush, or I just feel like they're being forthcoming. Like if there's a problem, they're talking about it. They want people to know about it and make their own informed decisions. So
right.
They're talking about
I hear a lot that people advocating for the vaccine have an agenda. I'm not sure what that agenda is, other than health. I hear a lot that are people profiting from it? Certainly, I'm not profiting from it. I mean, just in general, just people understand when a vaccine is given in the office. From it? Certainly, I'm not profiting from it. Just in general, just people understand the cost of the vaccine may or may not be paid in full by the insurance companies. You might actually lose money in the cost of the vaccine. And then you do get an administration fee somewhere in the $15 to $20 range. Remember, there's some supplies that go into that. So again, we're not really giving out these vaccines because they're profit, sources for us. So anyway, put that issue to rest. Profit. Sources for us.
Big topic.
Big topic. Do you think we can move on, or would we address it? Okay. And by the way, we are here to answer phone calls or comments or questions. Anything relating to the healthcare is okay. Medical questions about the wonderful economics of healthcare. This amazing industry that we have called the healthcare industrial complex. It was amazing industry that we have.
It's big business.
It is, and it's getting bigger. And how can something not get better as it gets bigger? It is.
Bigger and better.
Bigger must be better. It's a little blurb here. We like to give evidence-based recommendations, because, and I it's a little blurb all day, try to adhere to guidelines and give my patients accurate recommendations. But have you ever heard about blockages in the arteries of the carotids?
Yeah. We're altering ultrasounds a lot.
The arteries of the carotids.
Yeah.
I don't want to implicate anyone.
Ultrasounds.
So why? Why would we do that test? And I don't want to implicate things anyone. So why? There's always kind of exceptions, and it always comes down to case and physician judgment. But the famous United States Preventative Services Task Force, the USPSTF, which is kind of the standard bearer on what's recommended for prevention. They focus on kind of preventive topics, and they issued what's recommended for an update recently. For screening for carotid artery stenosis, that means no symptoms. They're just kind of doing it. They gave a D recommendation, which means don't. Just kind of doing it. So they say don't. They recommend against screening in adults without symptoms. For example, those without a history of a TIA or something called a mini stroke. For example, those without a history of stroke, any other neurologic signs or symptoms that may be caused. History of stroke, and they want, instead of kind of doing a test like that we should focus on other topics that have been proven to be important and beneficial. For example, screening for high blood pressure in adults, topics that have been proven, encouraging tobacco cessation, for example, promoting a healthy diet and physical activity, encouraging tobacco, recommending aspirin use when appropriate. That one, caught me by surprise a little bit. A little clarification there. And this is an important one too. Advising statin use. That's for cholesterol. For the primary prevention of cardiovascular disease. So primary prevention means you don't have it yet. So we're trying to prevent it from ever occurring. There's primary prevention means you don't have it yet. So it's for adults between 45 and 75 who have one or more risk factors, which could be high cholesterol, diabetes, hypertension, smoking, and those with a 10-year history. I find that the recommendations for cholesterol treatment are a little complicated, and I would very much like some standardization of that treatment. But the point is that routine carotid testing really probably should not be done. The point is that there's always. What about a case of someone who has multiple risk factors, and we already know that they have blockages elsewhere? For example, maybe they have had multiple risk factors, and we already know that some heart problems, need a stent or whatever. Maybe they have had. Every now and then you'll see a doctor kind of put the stethoscope up to the neck. Have you ever seen that? We're listening to something called a bruit. A bruit, I think, is French for just kind of noise. We're listening to something called a bruit, and it's kind of like a murmur in a way. Bruit, I think, is French for just kind of noise. That would be kind of a blockage in the carotid artery. It's kind of like a murmur that's causing a little turbulence. That's part of just
pointing to the side of your neck when you're saying that. So your carotid artery is located where and does what? Saying that.
Carotid artery is a major artery that supplies blood to the area above the neck. You see it in the movies when someone's on the ground and they'll come over and kind of put their couple fingers on the neck. You see it in the,
feel the pulse.
Bones McCoy will turn to Captain Kirk and say, "He's dead, Jim."
Feel the pulse.
Remember that? Bones McCoy will turn to Captain Kirk and say,
nobody knows what Star Trek is.
Jim.
You remember
that? I don't remember the reference that you're mentioned, but of course, Star Trek is a...
Dead,
I don't remember the huge part reference.
Just a country doctor.
Dead, Jim. Anyway,
just right here on the side of your neck,
and you can kind of gently. We always use the word palpate. You can gently just feel the area and probably detect your carotid pulse, which is a big deal. You need that blood supply. However, our body is amazing. You got two, and you also have something called the posterior circulation, kind of like a back road. So even if you have a blockage here, you still have the other side, and you have the back side. So if you have a blockage, it's ironic. 100% blockage. We really don't do much about. What we're looking for is 60, 70, and upward percent blockage. Sometimes those patients need to have it cleaned out. What's called an endarterectomy. The concern is not so much that this blocks. What happens is those blockages in your carotids can break loose, and then they can break loose and go to your brain and cause either TIA or stroke symptoms. And that's usually part of the workup for someone who has a possible stroke, a possible TIA. So So that's usually part of the workup image for someone who has. That's different than screening. That's an important point to make.
What's a TIA?
TIA is transient ischemic attack. It's kind of like, also commonly called a mini stroke, and it's a stroke. Kind of by definition means that enough brain tissue has been kind of irreversibly damaged. It doesn't mean it'll recover. TIA, that really doesn't happen. Whatever happened, kind of like didn't last long enough to cause any permanent. That really doesn't happen. Whatever happened, however, it can be a it can be a harbinger of a major attack, a major stroke. So it can be a harbinger. It's a fairly common reason for someone to be kept overnight in observation at the hospital. It's a fairly common suspicious symptom. For someone to be kept overnight.
What do you do for that?
At the hospital. I'll talk about that when we get back. All right, we're going to our first break.
Okay, thank you, Dr. Eric Stamberg and Robin Baker. Thank you for being with us, listeners. You are with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at My Community Radio. My name is Dan Gaddis, and it is Monday, June 7th, and 66 degrees right now here in downtown Kingston. Sunny to partly cloudy today with a high up to 93, which is a record high for today. Tonight, mostly cloudy, a low of 69. Tuesday, 80% chance of scattered showers and thunderstorms in the evening, and continuing. Tuesday, 80% chance showers and thunderstorms in the morning and continuing into the afternoon. A high of 85, and they do continue throughout the night. Tuesday night, continuing showers and thunderstorms before midnight, and a low of 66. Tuesday night, we'll be right back. Continuing showers and thunderstorms before midnight, and
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5 W223CR FM Kingston, New York. Magic 92.5.
Central Hudson reminds you, when you're doing yard work, safety matters. If you use a ladder, be aware of overhead electric lines, including the service wire that runs to your house. Even wooden ladders can conduct electricity with dangerous results. And be very careful if there are electric lines above or near a swimming pool, and you're working with skimmers, brooms, or other long-handled tools. Central Hudson wishes you a safe summer.
Hi, I'm your host, Smokey Cole Bear, filling in for Smokey, because after 75 years of...
Only you can prevent wildfires.
Turns out there's much more to say. Nearly 90% of wildfires are caused by us humans being careless, dumping our used barbecue coals willy-nilly. Guess the song was wrong. We did start the fire. That's why I respect Mother Nature and her trees, whether coniferous or new car scented. Brought to you by the U.S. Forest Service, your state forester, and the Ad Council. Whether coniferous or new car scented. Brought to you by the U.S. Forest Service.
Hi, this is Cameron Rylands from Kingston, and I support Kingston Community Radio because it's informative. Hi, this is Cameron Rylands from Kingston, and I support Kingston Community Radio because it's informative. Hi, this is Cameron Rylands.
Here with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. It's 7:32 a.m. and Kingston Community Radio, AM 920 and 92.5 FM. Here in Uptown Kingston on June 7th. Kingston Community Radio is talk radio, and your call-in number is 331-9255. 331-9255. This upcoming portion of Kingston Community Radio is brought to you by Central Hudson. And let's welcome back our host. This upcoming portion of Kingston Community Radio is brought to you by
thank you. Welcome to the second half hour of this morning show. Good morning, Ms. Baker.
Hi, everyone.
And what did we do on Friday night? You and I went out to dinner, didn't we?
We did.
What's the name of that restaurant? How do you say it, Dan? Ms. Baker.
Hi, everyone.
And what did we do on Friday night? You and I went out to dinner, didn't we? And what does that mean? Is that like
most commonly known as La Canard?
Yeah. Most commonly known as Canard.
Right.
The Canard.
And what does that mean?
We like to say the
La Canard. Yes.
Yeah.
But most commonly known as Canard. It's an interesting history.
We like to say the
because La Canard is just saying meant the same as being legally. It's an interesting history.
We like to say the
swept off your feet because you were tricked. Meant the same as you're a chained duck. swept off. So that's what Le Canard enchaîné still means. It means that you're a chained duck, or it's it's a chained duck. But that's what the Le Canard enchaîné still means. I mean, there's a little loose relationship between. But duck being a very signature dish at Le Canard.
Yes.
It's very true. But it comes with an interesting history because the idea of being tricked was also became the title of a very famous and still widely distributed satirical newspaper, satirical political newspaper coming out of Paris and still in around 1910 during World War I. Called Le Canard enchaîné. That's the name of the paper, and it's still a very scathing and very incisive and very investigative, great paper. And it's still a very satirical newspaper on European politics. So it was probably named, between the Maddens and Jean-Jacques Carquiat. It was probably named. So it was probably mostly because of between the Maddens
and what do you call the thing that the guy comes up and cleans the crumbs off the?
You almost named it crummer.
It's a crummer. Robin said it was a scraper. That the guy comes up and cleans the crumbs off the.
I stand corrected.
You almost
named a crummy job. It's a crummer. Robin said it was a scraper.
It's an interesting little tool because it works so well, but it's only $1.
Crummy job. All right. So now we learned a few things unrelated to medicine. We learned what the chain duck story. Now we learned what a crummer is.
Yeah.
All right. So we had a wonderful meal, and Dan was there. The chain duck story.
It was remarkably wonderful to see. It's funny because out of context, when you first peeked into the door, and I welcomed you in that. It was remarkable. It's interesting when you see people that are out of context from another environment. Like for instance, we see each other every week here. But when I saw you at the restaurant, I didn't make the connection right away. It was really an interesting here.
Kind of like a kid when they see the third grade teacher at the supermarket.
Yeah, exactly. Same idea.
They got that look. She exists outside of the classroom.
That's an interesting thing about The Office too, because you can't act. The only job where you can't say you recognize someone.
I can't acknowledge my customers. I say hi to someone. Robin's like, "Oh, who's he?" I'm like, "Oh, just some guy."
Say you recognize them. I have no idea where I met them.
Yeah, just saying hi to someone. Robin's like, "Oh, who's he?" I'm like, "Anyway, some guy." So we do have a guest coming on after the 8 o'clock hour, but I wanted to visit one of my favorite topics. By the way, you and I were talking about this before it was cool. We do have a guest telemedicine 8 o'clock hour, but
it's cool.
No, actually, I think the shine has faded. Telemedicine.
There's a certain context where it's really working out well.
Right. The shine has. So you and I we talked about this before COVID. Because I was kind of skeptical about that, and what I call an industry push. That this is the next wave. This is gonna fix what's wrong with medicine. I've heard that so many times in my career. I heard it said about urgent cares. They were going to fix what was wrong with medicine. I heard it said about the hospice movement. They were going to fix what's wrong with medicine.
What's wrong with medicine?
Electronic health records were going to fix everything that's wrong with medicine. The medical home concept was going to fix everything that's wrong with medicine. And now it's kind of electronic health records were going to fix everything.
What's wrong with
medicine? What is wrong with medicine? You really want that to be the topic of this morning?
Well, that's an interesting question, don't you think? Because if all these things are going to fix
what
it,
is wrong with medicine? Right. You really want that? My opinion is because it's become a field about doing rather than thinking. And when you focus on doing, we do more, and we talk less, and we think less, and we get away from the type of care that I think is really more valuable in the long run. Anyway, so none of those solutions really help that. In fact, they led to, and not those solutions that I just rifled off. They all have value. So none of those solutions, dismiss the urgent care, for example. And urgent care has a role. Those solutions, but when it first came out, kind of about 30 years years ago. The idea was, they were going to take pressure off of the emergency rooms, and so they were going to be good. Well, here we are 30 years later, ERs are more crowded than ever, so I certainly don't think that helped with anything. Anyway, so telemedicine, before it was cool. We said that there were maybe 3 roles for this type of telemedicine. The first was if there is a service that's just not available locally. Maybe 3 roles. I always think of an analogy. Maybe a young boy or girl in rural Montana gets juvenile diabetes, and maybe the nearest specialist for juvenile diabetes is in Boise or I don't know, Minneapolis or somewhere. So this is a scenario where a type of remote care is appropriate. I think it has a role and will have a role in longitudinal care, whether it's primary care or specialty care. For example, if I have a patient with diabetes and they just have some labs that just came back and I want to go over them, does the patient need to come in? Not necessarily, so we can potentially do a televisit like that. And then the third reason, which was the one that I was most concerned about, the one that I heard most about, was kind of this televisit. And then the third reason, urgent care model without leaving your home. That you were going to hold up your phone and talk to someone. And concerned that was going to lead to inaccurate treatment and over-treatment. We're going to hold up your phone and talk to someone. So one study I like to quote, it was done at the University of Pennsylvania. And one study I like to quote, and studied something very specific, which is antibiotic prescribing rate. Before COVID, this was something we talked about a lot. In the age of telemedicine, something very specific, which it seems to, in the age of COVID, it seems to not become an issue that gets discussed. Something we talked about a lot. What's the right way to prescribe antibiotics and the rate? So the headline was telemedicine tied to more antibiotics for kids. Study finds fewer children got the drugs at urgent care clinics, even less when visiting doctor's offices. I read an article like this, and maybe I have an agenda, but I sit there and go, this makes a case for primary care. So we're looking at that specific thing. Okay, so let's see. Sniffling, sore-throated kids seen via telemedicine visit were far more likely to be prescribed antibiotics than those who went to a doctor's office. Sniffling, sore-throated kids. The study's about 2 years old now. Seen via telemedicine visit. Many of those prescriptions disregarded medical guidelines, raising the risk that they can cause side effects or contribute to the rise of antibiotic resistance. Many of those prescriptions disregarded medical guidelines. So it was a study out of the University of Pittsburgh, someone named Dr. Kristen Ray, and she's not sure what type of doctor she is, but it's pediatrics, so whether or not she's a general pediatrician or a pediatric infectious disease specialist. Okay, so they looked at 340,000 children who had an acute respiratory illness in 2015 and 2016. So then you could argue, okay, it's already 5, 6 years old, this data. So maybe there's been some improvement. Patient received prescriptions for antibiotics more than half the time during telemedicine visits, compared with 42% at urgent care and 31% at doctor's office. Antibiotics more than half the time during telemedicine visits. And they found that 4 out of 10 prescriptions dispensed via telemedicine were not following guidelines. 3 out of 10 from urgent care and 2 out of 10 in a primary care doctor's office. And I just think this is a really from urgent care and 2 out of 10. And by the way, this topic never gets asked. This question doesn't get asked too much. When you look up things like telemedicine quality, it's just all. By the way, this topic never gets asked. Industry driven. No one really steps back and says, "Let's just compare these things." Like
but Dr. Stamberg, I don't feel good, so I go to the doctor. I have a telemedicine visit, and I don't feel good. I'm stuffy. I'm congested. I can't breathe. Blah blah blah. Like I want to be treated. So I don't want to be told there's nothing I can do for you. So how do you be treated? Alleviate that kind of attitude when a patient has it. I can do for you.
First of all, it's not easy. I mean, remember some of it was a problem kind of also caused by the medical industry that gave out antibiotics, pretty handily in the 60s, 70s.
Yeah, but what?
Also caused by the medical
I'm being
industry that
sarcastic.
gave out antibiotics.
What harm will it do?
Yeah.
Why? How come you can't just give it to me?
Yeah,
but like, I don't feel good. Why don't you just give it to me? If I have a virus and it's not going to help anyway, what harm is it going to do? Like, I don't feel good. Why don't you just give it to me? What would you say to a patient that's saying that to you? It's not going to help anyway.
Right. And you know what you hear a lot is, hey, whenever this happens, my old doctor gave me amoxicillin. Your stuff like that, So the harm of it is, well, first of all, not really harm, but it's just not necessary. So why are we doing anything not necessary, right? We talked about the risk of an allergic reaction. It's ironic. Well, first of all, worried about maybe an allergic reaction to the vaccine. Why are we doing anything? Sometimes they might be willing to take a medication that
potentially could cause an allergic
reaction. It can lead to other side effects, not necessarily an allergic reaction, but can cause
an allergic reaction,
particularly gastrointestinal side effects. You could eventually become resistant, and that's a common story too. And when I get that story, oh, my old doctor gave me amoxicillin all the time, but then it stopped working. You could eventually become resistant. So, that's now a person who probably has resistant bacteria in their sinus passageways and needs a more broad antibiotic when they get it. There's something called C. diff, Clostridium difficile, which is a bacteria that kind of lives normally in your gut, but when you allow antibiotics to kill the normal good bacteria, the C. diff will take over. And that could be very serious. So anyway, that's seen in people who are on antibiotics, and the more antibiotics, the higher the risk. But I've seen it in people who were just given a course of amoxicillin. So anyway, that's seen in people on antibiotics, and whatever more antibiotics, the higher the risk. But I've seen it in people who were just kind of a.
Well, anybody who's ever suffered with that infection, that's C. diff, doesn't ever want to have it again. It's terrible.
Yeah.
With that infection.
And again, I've seen it in just people placed on one antibiotic for relatively innocuous reasons. Yeah. That's why when we tend to now tell people to take probiotics, ironically, when they're on antibiotics, in an attempt to kind of keep the normal. That's why what's called the flora, the normal intestinal flora, when they're on antibiotics, in an attempt to kind of keep the normal. Women also are prone to yeast infections too. Because, that's common. That happens too. Okay, whenever this happens, in the past, my old doctor gave me amoxicillin. And by the way, he also gave me diflucan because I always get a yeast infection. Okay, whenever so you can see kind of like the incongruous, thought process going over this visit. I want an antibiotic that so you can see kind of that I think may not be necessary. The patient wants it. At the same time, they're prepared to treat the side effects of the antibiotic with another medication. So put it all together. So it's hard to kind of re-educate people. And when I look at a study like this that says 30% of primary care visits, to me that's 25 years, 30 years of effort and education and outreach. They get a guy like me and all the pediatricians. And by the way, have done an excellent job of decreasing the antibiotic prescribing in the field. But it's been an ongoing effort with good results. We don't ever really get feedback like this. Primary care. And in the era of COVID, it all kind of like got out the window. It's kind of justified by telemedicine. You look at reasons. And you go to any commercial telemedicine platform, where you could even without insurance, you could sign up for whatever the cost is to get care. You list the reasons, for example, they'll say urinary tract infections. Anybody who actually practices medicine will tell you that it's common for people to think, particularly women, that they have a urinary infection. And then when you check the urine in the office, they don't. So how you're going to be able to even make that diagnosis and treat it over the phone is very or telemedicine. So how you're going to anyway, so the shine of telemedicine has faded. Or telemedicine.
You're still offering it at your office?
Anyway,
we are.
So we are. I do 2.5 days a week, and I did this morning. Will be a telemedicine
still
morning.
Offering it at your office?
We are. There's still problems with the platform that are probably operator dependent. In other words, me or the patient kind of screwing something up. But I always hear that the industry kind of says, well, look, it's just the platform itself is fine. It's the people that don't know. I always hear that it's kind of like it's not. Look, it's easy for a person to use. They're not going to use it. So I think that one of the reasons that the shine has faded kind of like because of it's just kind of a pain in the neck. They're not going to use it. Don't want to deal with it. It's one more thing you got to log into. By the way, it's like when they're waiting. I don't know. They don't really know what they're waiting. I've logged in for some of my own medical care. You don't even know if you're logged in right. You're just kind of sitting there. For all you know, you're. I don't know. They don't really know what they're waiting. I've time. You did everything wrong. So there's a lot that needs to be done, and that's part of the problem. The good news about I think the shine fading is I think people want to come. So there's a lot that into the office. I think the good news, that's the doctor-patient relationship. It's not something over a screen. It's something that's better. Anybody who tries to tell you that a telemedicine visit is as good as an in-person visit is lying. And that even includes things like you talk to any psychiatrist, they would say, yes, it's the way things are now because there's only so many of us and we're all spread kind of thin. But yes, I very much would rather just be in the room evaluating things are now because with all those nonverbal clues and just kind of. But yes, I very much would rather
feeling
in the room evaluating
feeling.
With all those. So the other article I wanted to mention was something called telemedicine is a tool, not a replacement for a doctor's touch. This writer of this article, this comes from, actually I read it from a Louisiana newspaper. But the story is very common here. Let's see. This comes from, actually I read it from a Louisiana newspaper. It talks about a relative who had a rash. When he first noticed a curious rash, a relative was first directed, my relative, to the author's relative, to a practice's telemedicine portal and billed $235 for a 5-minute video appointment. And that's a lot of money. I don't, since rashes are often hard to evaluate in 2 dimensions, he was told he needed to see a doctor in person for the diagnosis and then was charged $460 more for that visit. In 2 dimensions, he was told he needed to see a doctor in person, and then ultimately he was told to see a dermatologist, which cost him even more. So I guess the point you're trying to make was that the telemed visit was a waste of time. He just added to the cost of seeing a dermatologist, and I guess that is a reassuring. A waste of time. And I felt that early, even my exposure to telemedicine before COVID, I felt that was the case. I felt that they almost betrayed their own confidence. I felt that early, when my exposure to telemedicine recommend that someone go to the emergency room, or just ironically call me, the next day because whoever was evaluating the patient via telemedicine, the stranger, was really not ironically call me, the next day because doing much. Whoever was evaluating the patient via telemedicine, a failed platform, was really not ironically call me. The payment is still kind of controversial, and I think there's going to be some battles going on with payment for telemedicine already. Where there's a lot of insurance companies are balking at paying for visits that were for COVID testing. Going on with payment for telemedicine already. Where many visits to urgent cares were done at paying for COVID testing, and insurance companies are basically saying there was no need for an evaluation. Like if a patient came in and really they just needed a test, someone's got to order the test. That would be someone like myself. So usually you evaluate the patient. You go in, you say, why do you need a test? I agree. Here's the test. I mean, that is. But insurance companies are saying that's not a service that's worth paying for, and now they're not doing it, and a lot of payments are in limbo here. And then I think it's just a matter of time before they're going to say, we like telemedicine. We're happy to have our patients still do it, but you know what? It's not the same thing as an in-office visit. Therefore, we're going to pay less for it. We like telemedicine, and I think you're going to have our patients still do it, but you know what? So we'll see. We'll see what the future holds. But you and I, Robin, you didn't know that you were prescient. Did you know that?
I feel like I am.
But you and I, Robin, you didn't know that you were prescient. Did you know that? Because we were, sounding kind of like the alarms about this before it became kind of the thing.
Well,
because we were.
I don't know if it would ever have become a thing,
right?
Without this, unexpected pandemic. I don't know if it would people have ever really wanted it and unexpected developed it and pandemic. I mean, you and I before COVID hit, we were discussing things like there was a big story that broke in California about a family that was given horrible, devastating news over a teleprompter by a robot doctor, and how terrible that was, and how insensitive that was. To not even have a physician in the room with you giving you devastating medical news. And how physicians. People were just astonished and couldn't believe that would happen, And so there it was happening, and we were appalled by it, but, it wasn't an option. I mean, there was no one going anywhere, and no doctors were having anybody come in to see them.
That story might have predated COVID.
There was no one. Yeah, it was before COVID. No doctors were having anybody come in.
When I read the full article, that story might have predated COVID. I guess just the story was that the bad news was not broken in a sensitive manner. When I read the full article,
So, I mean, just working in a doctor's office, I mean, there was never a time when I was not expected to come to work. But I was at work in an office where there was no patients. None. No one was allowed to come in. So I was at work in an office where there was yes, we were given a violent shove. That's what I call it, into a technology that it was better than nothing. Like if you didn't feel well and you needed to speak to your doctor, this was better than not being able to see a doctor at all. And nobody wanted to go to urgent care. Nobody was going to the ER unless absolutely necessary. So yes, it became a necessary and effective platform in this case.
Right. I use the phrase shock doctrine, which is that's usually used in a political context. Something bad happens, so a government will respond, take advantage of that, and maybe change some laws or whatever. So this was, the shock of the pandemic kind of enabled the industry of telemedicine to capitalize on it. The shock to forefront. But you know what? I don't think it's taken. At least not taken well enough. Now sometimes you read the articles. They'll say they're in for the long game. They don't care about. I don't think people in their 70s and 80s not figuring it out, or people even like me and you, not figuring it out. It's about the future.
It's the 20-year-olds that will someday be 50 that
so if the
are on top of this technology.
And I read that about, I read that too. It was just a fairly recent article about what millennial patients want. And I read most of that saying, I'm not so sure they want this. I think that this is what's been kind of sold to them. They want the doctor to be easily accessible. They want things at their fingertips. They don't want to, they want,
the truth is kind of, if we want it or not, it's kind of here. I mean, you and I are holding a phone or wearing a watch that can tell us what our pulse is. It tells us what our blood pressure is. It tells us. These are amazing technologies where people are, they're able to. It tells us what our blood pressure is.
But it's just not as good. It's ironic. We talked about
a diabetic device that's attached to your arm that you can just slide your.
That is a good device.
Slide your phone over and it tells you what your blood sugar is right now. I mean, there's amazing technologies, and so people are really taking care of themselves. Something that in the past was only able to be done by the doctor or a finger stick or.
No, I agree. I mean, technology is a tool, but not a replacement. I agree. That's a different subject. Kind of those cutaneous glucose monitors. They are good. They're just not for every diabetic, and just because you see commercial TV doesn't necessarily mean it's appropriate for you. It generates phone calls,
or that it's going to be covered or paid for. I mean, there's so many caveats. So
it's not easy. I usually wind up preferring. Phone calls
aside, but I usually wind up referring there's so many caveats.
An endocrinologist.
Because they can get things covered easier.
I usually wind up. It's sad in a way because it's not really an appropriate use of their skills. You know, and you know what? And that's sort of the point I try to say to patients. It's sad diabetes is not okay right now. They're not going to approve it. You know, type 1 diabetics. That's sort of the point is very important. And anybody who's got type 2 on insulin, just difficult to control diabetes, they would benefit. They benefit. It's very important. But if someone is on metformin and their A1Cs are fine, it's really to control diabetes. You know, not something they necessarily need. And insurance companies know that, which is why they're paying the neck about it. And their A1Cs are fine. Anyway, how do we get on that side?
We were talking about the new technology and how that you were saying that they're in this for the long game. Like it's okay if the elder population isn't catching on to telemed, but eventually, like the kids, it'll kind of be what they know. Well, I got to see the doctor. Let me just catching on to telemed.
And by the way, that's
bring up a video.
And that's industry in a way. They have created a product, and now they're going to create the need for the product. And by the way, you know, and there's the irony. I mean, I feel like I have a product. My product is, you know, the care I provide all day long, which I prefer to be in person rather than telephone. And that's the product. Not this. You know, product is your provider. I prefer to be in person rather than I think that's been kind of a theme throughout my whole career. You know, what exactly? You know, if healthcare is an industry, which means there's a product that's being sold and consumed, what exactly is the product? And you know, if what is it? You buy I put a cup of coffee. That's the product. You know, I went to my healthcare provider today, my doctor or nurse practitioner or PA, and something happens. So where's the product? What is it? Provider today,
your health and well-being,
or it's the service. You know, but that's sort of what leads to maybe the antibiotic demand. You know, that not really understanding what the product is. You know, the product is the prescription I'm leaving with. I call it something called a souvenir of the antibiotic demand. You know, that
you get some medicine when you leave. So
yes, you just souvenir. It's the prescription. Well, we have an alternative to that, which is give patients some information, which sometimes can work. All right, we're gonna go to our second break, and we'll see after the break. We have an alternative.
Thank you, Dr. Eric Stamberg and Robin Baker, and many thanks.
All right, we're going to go to our second break.
KCR is Kingston Community Radio, WGHQ, AM 920 and 92.5 FM, and streaming online at mykcr.org. KCR is Kingston Community Radio, and it is Monday, June 7th, and 70 degrees now here in uptown Kingston. This portion of Kingston Community Radio was brought to you by Central Hudson. And today it's going to be sunny to partly cloudy with a record high of 93 today. And tonight, mostly cloudy, a low of 69. Tuesday, 80% chance of scattered showers and thunderstorms in the morning. And continuing throughout the afternoon, a high of 85. And still continuing showers and thunderstorms through Tuesday night. And 67 is our low. And still continuing. We'll be right back after these messages through Tuesday night. And
thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5 Kingston and 92.5 W223.
You care for the house, the kids, and our future. A Shiro's day is never done. So let's start saving a little more now. Get free tips to help boost your retirement savings. Visit aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council.
Okay, kids, Dad's going to teach you how to dance. First, spread your feet apart. Then, a pump the knee.
Dance like a dad.
It's a great way to make a moment with your kids. Visit fatherhood.gov. Brought to you by the U.S. Department of Health and Human Services and the Ad Council.
Central Hudson reminds you that summer thunderstorms can strike with strong, gusty winds, knocking down trees and power lines. If you see a downed power line, call 911 immediately to report it. Power lines can carry an electric current strong enough to cause injury or death. Stay at least 30 feet away from a fallen line. Don't try to move it or anything that has come in contact with it. And never drive over a power line. Remember, your safety matters. Don't try to move it or anything that has come in contact with it. And never drive over a power line. Remember,
hi, this is Shirley Stave from Kingston, and I support Kingston Community Radio, and so should you. Hi, this is Shirley Stave from Kingston, and I support Kingston Community Radio, and so
You're listening to WGHQ AM 920 and 92.5 FM, the home of Kingston Community Radio. Monday, June 7th, 70 degrees now here in Uptown Kingston. Our call-in line is 331-9255. 331-9255. This upcoming segment of KCR is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs, and discover the difference of buying local. Sales ongoing for all of your home building, Herzog's and painting. Let's get back to the on-air studio with Dr. Eric Stamberg and sales ongoing. Welcome back.
All right, welcome to the second half of this morning show. We do have a guest. Dr. Michael Kortbus will be contacting us. Welcome to the second half. He's a local ear, nose, and throat doctor, and we're going to talk about Dr. Michael Kortbus, a new treatment for sleep apnea. Also, post-nasal drip. Robin pointed out to me that I was clearing my throat for the first half hour of the show. Anyway, birthdays. There's no fish. Nothing here in the folder, but there's an interesting card here. You see this card?
I saw it.
Anyway, birthdays. There's dogs and cats. Nothing here. And opening it up, it says, "Wishing you a wonderful birthday to Lawrence Maxwell."
Happy birthday, Lawrence.
Yes.
Happy birthday, Lawrence.
Lawrence is Lawrence Maxwell and his mother are basically owners of the station.
Happy birthday, Lawrence.
And,
absolutely. Happy birthday, Lawrence.
They do. So it says, "Love, Mom." Happy birthday, Lawrence.
Happy birthday, Lawrence.
Basically owners of the station.
Does he get a cow pie?
Absolutely.
It's a conflict. "Love, Mom." Happy birthday, Lawrence.
Not so much conflict. He'll probably just get out
Does he
and
get
buy
a cow
one.
pie?
Yeah, right. There's nothing in here.
Okay, so that was the only birthday. Not so much conflict. He'll probably just get out. Happy birthday, Lawrence.
Yeah, right. I go to meetings sometimes where they start by saying, "Does anyone have any conflict of interest?" I'll be like, "I got a free cow pie."
Happy birthday, Lawrence.
Yeah, right. I go to meetings. So anyway, yes, happy birthday, Lawrence. Any conflict of interest? I'll be like, "Well, I got a free cow pie." Ear, nose, and throat.
Otolaryngologist.
So anyway, thank you. I stumble on that word. Sometimes they call themselves head and neck surgeons because it is a surgical field. So I stumble on that word. And head and neck surgeon. I worked with one when I was a medical student. I had to get to rotate, and the doctor would say, "We're here to talk about your ears, nose, and throat," and I'd be like, "Aha!"
He's an ear, nose, and throat doctor. So last week we had an interesting first time. I've been working at the office for 6 years. I've learned so much by working in this.
Okay.
So there was a test ordered that I had never heard of before, and it was called an ENG. Have you heard of this test? So there's like another common test that's ordered is an EMG. M as in Mary. This was an ENG. So one of our rheumatologists was ordering this test for a patient, and didn't know if there was anybody locally that does this test or anything, and asked me to look it up and call some local otolaryngologists, ear, nose, and throat doctors to find out if they are actually doing this test. So the patient and I were, kind of curious. We had an idea what it was for, the test, but we Googled it and looked it up. And so what it does is test an equilibrium, patients having difficulty with balance, Googled it, and stability, vertigo a little bit, and this ENG, which I'm not sure exactly what those letters stand for, but it measures, helps you decipher if it's an inner ear problem that's causing.
It's the work about dizziness, basically.
Helps you decipher
giddiness,
inner ear problem.
Dizziness and giddiness, yes.
Someone was very upset one day when their clinical visit summary said that they had giddiness.
Dizziness and giddiness.
They were very insulted.
That is the semantics that they use. Dizziness and giddiness.
Said that they had giddiness.
So you want to know what an ENG is? Well, that's it's not a Asian food restaurant on Broadway.
No, but I looked at this right, or it's on MSG. But we did look it up, and I did find a local doctor who does this quite regularly, Dr. Mark Berry. We did look it up and referred the patient to. So
dizziness is I'm prone to say a big topic.
Huge
topic. topic, and it can be hard to evaluate. It's nice when a patient comes in and reads the textbook and says, "Doctor, when I move my head, the room spins." I'm like, "Okay, that's vertigo." Hard to evaluate. Or doctor, when I stand up, I feel like I'm going to pass out. Okay, that's known as doctor. When I move my head, the room spins. Doctor, when I stand up, I get a little woozy. I might pass out. Things seem to be spinning. I get a little nauseous. That's usually what the story is. So it's a little bit harder to delineate the cause of the dizziness. So yeah, and what type of specialist is appropriate to evaluate dizziness? I think an ENT is a good place to start. Sure, because that part of the ear regulates balance, and also the role of the eustachian tube. So people kind of have those clogged for allergies, or being on an airplane or whatever. You'll feel the role of the eustachian tube. It's not the same thing as vertigo. Have those clogged. So yeah, so I wouldn't order that test myself. I would probably have referred the patient. Sometimes I'll refer the patient to a neurologist because there are other causes of dizziness that are within the neurologic system. Sometimes I'll refer the patient to a neurologist. It's complicated. Because there are other causes of dizziness that are within sometimes it's the visit specifically for dizziness. Sometimes the visit is, the dizziness is kind of tacked on to the other reasons that the patient is already there. Sometimes the visit is,
right. I think it was specific to like a change, like from sitting to standing or from laying down to standing up. Like I think it was specific to like the patient's inability to adjust to that change, or from laying down to standing up. Like
I concur.
I think interesting, huh? The patient's
inability to so that is one reason. What are reasons that people commonly go to an ENT? Nasal. So that is one obstruction. Really difficulty with your nasal passageways.
I went once.
You went once? Why'd you go?
I had nodes on my vocal cords.
So yeah, that's a common reason I would refer the patient. Hoarseness. Hoarseness that's not explained and doesn't resolve. You got to have those vocal cords looked at. Laryngeal cancer will manifest as hoarseness. That's not explained. Yes, vocal cord nodules, an interesting topic. Usually seen in women more than men. You see it in singers. Beverly Sills famously had vocal cord nodules, and Robin is a singer. And then you see it in certain occupations. Teachers, mothers, always yelling at the kids.
People who talk a lot.
My favorite case was a patient of mine who had vocal cord nodules. She was a teacher who was a swim coach. So not only was she overusing her voice all day with her classroom, but imagine what a swim coach does. They're yelling, trying to cheer on someone who's underwater. So you're yelling even louder. So vocal cord nodules are usually kind of yelling overuse problem. Trying to cheer on someone who's underwater. For a singer, they could be yelling even louder. So vocal cord nodules are usually yelling overuse problem.
Like any muscle, they can be overused and then healed as well. You have the ability to heal from the overuse. Muscle, they can be overused and then healed as well. That ever happened to you? Heal from the overuse. Overusing your vocal cords?
On the air?
As well. Yes.
No, again,
overusing your vocal
I think it happens to women a little bit more than men. But anyway, we have our caller. Good morning.
Hello.
There you are.
Michael
I think it happens. Hey, okay. So thanks for calling in. Anyway, we have our caller. We were talking about you. Were you? Oh, I shouldn't make it. You are. I'm sorry. I was going to say, were your ears ringing? Thanks for calling in.
Oh, but don't change.
We were talking about you. I try not to make too many corny jokes. I was going to say, were your ears ringing?
Oh, hopefully it was something good.
That was it. Were your ears ringing? I try not to make too many corny jokes.
I love it when a patient, when I look in their ears and I say, how's your hearing? And
were your ears ringing? Yeah, I know. All right, so how are you, Dr. Cortvis? How's things overall? You know.
Everything is good. All
right, so how are you,
Dr. So my office is going to stay in Red Hook, but I'm going to be a professor of otolaryngology through Albany Med.
Wow, that's exciting.
Yeah, big development.
Are you going to be involved with training?
Yes, I have been through the 10 years of the existence.
Are you going to be involved with training?
Having medical students and residents and, sometimes high school students shadowing me and people trying to figure out their paths and And I do. I love teaching, and this was a good fit for me, as they have now 23 other colleagues in my field, and they're going to develop a department up there. They've been a division of surgery, Eric, for some period of time. 23 other colleagues.
So Dr. Corbis is a ear, nose, and throat specialist. What's the other term, Robin?
Professor of otolaryngology.
Yes. I asked Robin, assistants would say that, and I said sometimes also referred to as head and neck surgeons.
Professor of otolaryngology.
That's correct.
I asked Robin. Yeah, so you've been practicing in this area for, I'm going to guess, about 20 years?
That's close. Working on my 16th year now.
You've been practicing in this area for, and right now your office is primarily in Red Hook, right? Do you have another office or just one office?
Working on my 16th year now. I've come,
right now your office is primarily in Red Hook, right?
Stamberg, and I had an office in Kingston as well. I had an office right on Pine Street, and that was up until about 2012. And then I was in Hudson only, and then I was in Hudson and Kingston on Albany Ave on 325.
Right, I remember that one.
And you remember that one. And then I was in Red Hook alone, and now I'm actually seeing patients once a week in Hudson again at the medical office building. Then I was in Red Hook alone.
Yeah, you know what? As a primary care doctor, I never understood the multiple offices. Patients will drive to you. You don't need to have the satellite. All these different satellites. But all right, so Dr. Corpus, I guess we might as well just get to the kind of the major reason I asked you to come on. But I do want to maybe revisit some other general ENT subjects. Robin and I were talking about some common reasons that someone might be referred, someone like myself would refer a patient to you. So what is this new device? Is it called the Inspire?
It is called Inspire. Inspire is the name of the company. And
so what is this
if you
new
don't mind,
device?
I'll take a step back.
Stamberg
and
sure,
Robin,
please.
You just talk about sleep apnea in general. So sleep apnea is a very common condition. And I'll tell you, I'll see a lot of people with sinus problems and ear problems, and I'll simply look in their throat, and people who are listening can do this right in their own mirror when they're brushing their teeth. If you look in the back of your throat and you don't see the dangling thing called the uvula, the punching bag, remember from the comedy strip?
Yeah, they're very funny, the uvula.
If you don't see that well, that's actually a pretty high risk of having sleep apnea. And we have some people who live alone and don't have bed partners and don't really know if there's a sleep problem with snoring. Right. They might just get up at night and think that they're, have to go to the bathroom or something. And sure enough, we get now a home test. A lot of people are also nervous about going to the hospital and getting a sleep test in the hospital. But we can have a test at home through one of the hospitals or maybe even a private company, and they'll tell us whether or not there is sleep apnea. Now, sleep apnea means A means without, and apnea means breathing. So it means stopping of breathing during sleep. And where the ENT comes in is because the vast majority of it is called obstructive, meaning there's some kind of blockage of the airway in the throat. There's another kind called central apnea, which is a little bit more rare and can happen in severe cases of obstruction, where the brain simply doesn't tell the diaphragm to move it. It's kind of a subset of sleep apnea. But with obstructive sleep apnea, we have this issue where there is tissue in the back, and sometimes it's an issue of tonsils or a large tongue or something like that. But a lot of people then get prescribed that machine, which is called the CPAP, which is a machine that basically sits on the nightstand with a tube that supports the airway with pressure. It's not oxygen, it's just air under pressure. But a lot of people can't tolerate it because, people say I wasn't born with a hose going into my face. I don't like this.
I was using the word draconian earlier today to talk about the treatment. And it just reminds me when I was a kid.
The second
I was using the word draconian earlier today. Remember the
third is deviant septum. When I was a kid, a lot of people have deviant septum, and the air pressure simply can't go into the because of that.
I always remember the original Planet of the Apes movie. They had they were wearing some device that on their spaceship that looks a lot like the sleep apnea. I remember the original Planet of the Apes movie. They had
or even like Top Gun. Remember Tom Cruise with the fighter pilot face mask on. Back in the day, that was all they had, was one that went over the nose and mouth and chin, and basically took up your face, and that was a little bit more claustrophobia inducing than what they have now, which is called nasal pillows. Smaller things that go into the nostrils. Anyway, so it's a very common diagnosis, especially in the older population. I take care of children too, Dr. Stamberg.
Okay.
With children, it tends to be a tonsil issue. Not in everybody, but as the obesity pandemic, epidemic continues. I almost said pandemic, right? So everybody's lips. Epidemic. There are more and more people who have sleep apnea based upon simply upon the body weight. So if we have a patient who can't tolerate CPAP, an ear, nose, and throat doctor gets involved because, sometimes we get involved with the diagnosis. If we have a patient who can't tolerate the machine, we'll see if they have a DVA septum. If not, they might be a candidate of some airway procedure or even an oral appliance from a dentist. Dentists can make something that kind of pulls the jaw forward at sleep that opens up the airway. Because, to be honest, it's often the tongue itself. And to remove a person's tongue is talk about draconian. That's pretty barbaric,
Right.
And so then they came up with this machine. It's called the Inspire, and what it is actually an electrode that goes over the nerve to the tongue. Remember, the tongue is really where it's at when it comes to sleep apnea. So the electrode is placed with surgery over the hypoglossal nerve, which is the 12th cranial nerve, on one side, and that is tunneled into the skin over the chest, where an apparatus, a small electrode generating battery, if you will, is placed there, and under it is a sensing lead. So I dissect out the intercostal muscles, which are muscles between the ribs. We place a sensing lead so that during the nighttime, a person who has sleep apnea can turn the device on, and every time that a person breathes, it is sensed by the device, and then an electrode is an impulse is sent out through the electrode to the nerve to make the tongue sort of shrink or contract just on one side. And apparently, according to the studies, 95 to 98% of people have a reduction of sleep apnea to the point of not having it anymore. And apparently, according to the studies, 95 it's really effective. I have a lot more to say, but I'll stop there for questions.
Well, you use the hypoglossal nerve. It's not basically just people listening. That's the nerve that controls the tongue. Well, you use the hypoglossal nerve.
One of the only pure motor nerves.
So who's a candidate for this? Are these people who have maybe not been successful with CPAP, or is this in place of CPAP? So who's a candidate?
That is really where the finer detail lies. So I actually have had patients ask me, you know what, I think I have sleep apnea. I have never even worn the machine. Can you just do an I actually have had, but there are criteria set up by what's called CMS, right? The Centers for Medicare and Medicaid Services. The number one criteria is that you have had a sleep study. So you can't just walk in and say, I snore, I want the Inspire, right? So there's got to be a sleep study. And it has to be within 2 years of time. So if they have one 5 years old, we'll redo it. And then the second criterion is that they have had to fail CPAP. So now, in the past, it was pretty rigid, God bless you. It was pretty rigid, that it was thought like a person would have to use it for 6 months. But now all you need is a doctor's note that says, this person tells me that they can't tolerate the machine. So after that, we look at other criteria. So I don't know how your listeners are with the body mass index. So that is how the height relates to the weight of the patient. And so the body mass index has to be somewhere less than 35. It's a little bit here and there, 36, 37, maybe would get approval from the insurance company. But basically, the person can't be morbidly obese, and because it has been shown that they can't tolerate the machine. The next is this number that we quantify sleep apnea with, and I won't get into that detail, but basically, a person with mild sleep apnea would not be a candidate. It has to be moderate moderate or severe. Sure. But basically, as of now, Eric, and I do think this is going to change, we have to bring a person to the operating room and do something called DICE, which is an acronym, Drug-Induced Sleep Endoscopy. So we'll bring a person to the operating room, and just like when they have a colonoscopy, we have an IV that puts out that white stuff, the propofol, that makes people sleepy. And once they start snoring, I'll take a scope in the back of the nose, and I'll take a video to see where it is exactly and how the airway collapses on itself. It's a method of trying to replicate what happens in the bedroom. So that criterion, most of the people are candidates based upon that procedure, but I have to send that video actually to the insurance company, and they also have their experts who look at it. We're looking to avoid implanting somebody who has something called concentric collapse, which is we can't let the airway collapse upon itself in a circle. It's really, the back part of the airway has to stay fairly stable, and that's a candidate for the procedure. So clearly there's a lot of different criterion for the Inspire, but I have to say, with their marketing program, I'm getting a lot of people coming in who say, I heard it on the radio, I saw it on television, and they have some pretty, insightful advertising going on for a lot of people. Does that make sense?
Yeah, and I think obviously by my patients, I guess I'm going to probably start suggesting it to people who have the diagnosis but don't seem to be doing well. Yeah, I do have some patients. How you doing on your sleep app? I hate it. I never use it. I can never get used to it. That type of thing. They make me good candidates. It's interesting how, the link between sleep apnea and obesity, but the relatively low cutoff for the BMI. It's interesting how really leaves out a lot of patients.
I agree with you. Now, I should say that your parent company, Nubank, has a great bariatric program at Rhinebeck, and I've seen a lot of patients who come to me from that program. So I'm already seeing patients with sleep apnea from them because they need to be cleared for bariatric surgery. And in those cases, I would say let's do whatever that is. And typically these days, sleep gastrectomy rather than the Roux-en-Y bypass. I don't want to get caught up in that, but basically, bariatric would be probably a better thing. But one thing I hope the callers and listeners understand is that if you have sleep apnea and it's untreated, the amount of morbidity and mortality, meaning the possible diseases that can happen because of untreated sleep apnea, are pretty frightening. I mean, I'm not trying to scare people into things, but basically, stroke, dementia, cardiac arrhythmia, AFib, people on Coumadin, all these blood thinners, myocardial infarction, meaning heart attack, sudden death. In fact, ironically, the person who first trained me in sleep apnea was a 48-year-old male, a professor, who was walking his dogs on Thanksgiving morning. The only diagnosis he had was sleep apnea, and he had sudden death.
Wow. Sorry to hear that. I do know that a lot of the cardiologists seem to be recommending that workup for sleep apnea at some point. I do know that as part of their workup too. For the reasons you just said. A lot of the cardiologists seem to be. It comes
I
up.
think it'd be better. Like we're trying to do prevention, right? It'd be great if we can catch these folks when they're in their 30s and 40s. Of course, I'm not saying that somebody in their 70s and 80s can't have treatment. Of course, everybody should. But the point I'm trying to make is about the cardiologist is that they'll send us patients after the patient already has atrial fibrillation.
Right.
Everybody should. But the
right. And it comes up a lot with DOT physicals. I know there's some places that kind of really measure the neck size and stuff like that. But my review of the is really this. It's hard to kind of find an easy way to screen someone for sleep apnea other than their symptomatology. Does that make sense?
I have a couple of shortcuts. One of them is the 17 inches the cutoff. So if you have a husband who has a 17-inch or greater neck, that's a very strong indicator. Again, this whole thing I said in the beginning of looking in the mirror and seeing if you could find your uvula, that's a without touching your tongue. That's a helpful thing. And thirdly, how likely would it be if you're sitting in your reading room in the middle of the day reading a book? How likely is it that you're going to fall asleep in the chair? That's another sort of poor man's indicator.
The world of DOT, Department of Transportation. I mean, these are truck drivers, and we're trying to prevent someone from falling asleep at the wheel, basically. When you think about a lot of truck drivers that might have risk factors for having sleep apnea. So it's a tough decision from the person who is doing the DOT examination. And I would like a little more clear criteria from the Department of Transportation. These are federal guidelines. Anyway, but that's an aside. But it does come up in the realm of DOT exams. I always say, though, if they really were interested in screening, they should just have people get a sleep study before they get licensed. But that's a major undertaking, obviously. Anyway, so it sounds like your experience with this device so far has been positive, right?
It has been, and again, it's a little bit of a criterion issue at this point in time. And again, I think these are moving targets. I think that maybe the BMI numbers will shift. I think that maybe the sleep endoscopy it doesn't have to be done in such an environment, because I do endoscopies in my office many times a day, and I'm not so sure if it's necessary to determine that based upon that added expense of bringing a patient to the operating room. And anyway, but it's a technically elegant procedure. I think that patients do very well with it in my experience, and I think the numbers are going up. Again, it's been around for about 10 years. I just think that now there's been some greater funding into the company to really sort of get it to take off, and they want to have it so that every area or region has a surgeon who can do this procedure. And as of now, I believe I'm the only person in the Hudson Valley who can do it.
Wow. Well, that's great. What hospitals are you working out of right now?
Northern Dutchess in Rhinebeck and Columbia Memorial in Hudson.
All right, good. And let's see. So we're going to go. We're going to break. I have a few more questions. Can you just kind of hang on after the break, or do you have to get going?
Absolutely.
Okay.
Yes, I will.
But I'm already, my mind is churning with patients that I think might be a good candidate. So you might get some cases out of this.
Perfect. Thank you.
And they always want to reach out to the primary care guys, because we're the ones that need to be aware of options for our patients. All right, so we're going to go to our break. Thanks for calling in. Hang on.
Thank you.
All right.
Yes.
Okay, and thank you, Dr. Eric Stamberg, and thank you, thank you, Robin Baker, and especially Dr. Michael Kartpas for calling in today and being with us up and through this next half hour. You are listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM, WGHQ. Monday, June 7th, and it's 72 degrees now here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Herzog's. Herzog, stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. Sales are ongoing at herzogs.com. Mid-Hudson Valley weather and forecast, sunny to partly cloudy today with a high of 93, which is a record high for today. And tonight, mostly cloudy, a low of 69. Tuesday, 80% chance of scattered showers and thunderstorms in the morning and continuing throughout the afternoon, a high of 85 on Tuesday. And Tuesday night, continuing showers and thunderstorms, especially before midnight, a low of 67. We'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Hey, Dad, your prescription will be ready in just a minute. Hey, Dad, your laundry will be ready in just a minute. Dad, your lunch will be ready in just a minute.
Hey, honey, why don't you take a minute? When you help care for a loved one, you give them as much time as you can. But it's just as important to take time for yourself. AARP can help. Find free care guides to support you and your loved one at aarp.org/caregiving. That's aarp.org/caregiving. Brought to you by AARP and the Ad Council.
Okay, forest animals, kids are coming to the forest, and it's up to us to make their visit a good one. Sparrow, have you practiced the most popular bird songs for the year?
Of course.
catchy. I like it. River, how's the temperature?
It's a refreshing 52 degrees, man.
I love it. Turtle.
He's not here yet, man.
He's late every morning. Okay. Squirrel.
The forest has been preparing just for you. To learn more about cool things to do in the forest, visit discovertheforest.org. Brought to you by the U.S. Forest Service and the Ad Council.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio, so please keep listening and supporting our station.
And you're with us here at KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. KCR's Talk Radio, your call-in number is 331-9255. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker and Dr. Michael Courtbus. Welcome back.
All right, thank you. Welcome to the last half hour of our show this morning. We have on the phone Dr. Michael Courtbus, a
otolaryngologist.
All right, primarily out of Red Hook. He works, performs surgery at the Northern Dutchess Hospital and also Columbia Memorial Hospital in Hudson. And we've been talking about Inspire, which is this device for sleep apnea. So insurances are covering it, but they're not making it easy on you.
Yeah, it seems like when the FDA approved the device, it was set up with these criteria, and the insurance companies stuck with them. And once something is kind of solidified in that fashion, it's hard to change that.
Right.
Not impossible, but they're working on it, and as the public becomes aware of it and patients desire it, I think that's going to be where it's at. Just like in everything else, and this radio station, the public. I was just listening to the commercial, and it's true. We need people's voices to stand out, and when people speak up to their insurance companies and talk to them from that level, that's when things get done.
Yep. That. I agree with you completely. I'll tell you, it's a challenge though. So I'm just happy that that it is an option, and I'm glad that you're a local provider who could perform that for patients if appropriate. Last time you and I had you on the show about 2 years ago. I was looking at it almost exactly, to be honest with you. You were also talking about a lot about postnasal drip. This is such a bane of existence for so many people. Robin scolded me for clearing my throat on the radio this morning. So you mentioned the procedure about kind of freezing it. Is that something you're still doing?
I am, and the results are also very good. Fact is, it works on, according to the company, 85% of people who have the procedure, it has an effect. And sometimes, again, we have to clarify, is it curative? In some, I have had people like, wow, this worked really well, and I feel cured. But in many, it's just to the point where it's better and acceptable. And when I say it, I mean the sense of mucus in the throat. I think I haven't had a patient, maybe one older man who had some other medical issues going on who didn't really feel an effect. And it's somewhat hard to quantify, isn't it? Like, how do you quantify it? But the fact is, I do it. I'm happy with it. But let me take a step back again, if you don't mind,
sure.
Stamberg. So postnasal drip, in my opinion, and I might be a little bit, sort of on one end of the bell curve on this one,
right.
Is often has nothing to do with the nose or gravity. So you remember post-nasal drip, the phrase is loaded with meaning. So post is behind, nasal means nose, of course, and drip is gravity, right? Something doesn't drip in the vertical direction going up. So when I tell a person you might have this thing called reflux, a lot of times it's like, wow, what is this doctor talking about? Because a person will say, I don't have heartburn. But, cough, hoarseness, throat clearing, post-nasal drip, mucus, a feeling of a lump in the throat, food or drink going down the wrong pipe, what I like to do in circumstances when a patient has some of these symptoms, I say, let's get a gastroenterologist to look at the esophagus, look at the stomach, make sure everything's okay down there. Do you feel the same way, Dr. Stamberg?
Yeah, my evaluation, I'll usually ask about gastrointestinal symptoms, but it certainly is part of the workup. I also start by saying that we really don't. I don't know. It's tough to offer people treatment for the post-nasal drip. I guess I usually recommend a nasal steroid, but that kind of contradicts what you said. That it's a minimal benefit. And an antihistamine of some sort.
Let me go into it. I do. I think of course, nasal steroid is over the counter, and it's a very safe thing. And in Ulster County and Dutchess, a lot of people hear the word steroid, and fright becomes an issue. Right? There's a concern about that, and that's a well-grounded concern, by the way. But here's the thing: the symptoms of sinusitis are nasal obstruction, meaning you can't breathe well through the nose. Facial pressure, and I'm not talking a piercing unilateral headache. I mean just like a dull aching pressure.
Right.
The sense of smell is disturbed, whether it's too much, meaning you smell things that don't exist, or your smell isn't working at all.
Right.
And the last is, things of a opaque or thick nature coming out, meaning like you blow your nose and you've got some thick mucus, which might have color and might not.
Right. That's a good point, because people are still obsessed about the color of the mucus.
Right. And by the way, let me just go on a quick little tangent there. The color of the mucus is defined by an enzyme that we have in our white blood cells called myeloperoxidase. So if you have yellow mucus, it doesn't necessarily mean that you have a bacterial infection. It might mean that it's allergies or some other rhinitis that's not bacterial and does not need an antibiotic. I think that the thought of that color being automatically bacterial is a little passé. I do. I think when a person says to me, I have postnasal drip, if you clarify, what they mean to say is that there's mucus in the throat that they can clear. Sometimes they clear, sometimes they don't.
Right.
And they can expectorate it. And the fact is, if you look at it on a cellular level, what it is actually your own mucus coming out of the glands, of the salivary glands that line the entire throat. And they're in response to something. And that something, Dr. Stamberg, typically is either acid, pepsin, or bile. So a lot of patients will say, I saw my GI, he has me on an acid medicine, and it's not working. It doesn't necessarily mean you don't have reflux. It just means that we don't have a medicine for bile and we don't have a medicine for pepsin. But those three entities independently create mucus in the throat. Does that make sense?
Yeah, it's common. Sounds a lot more complicated than I thought.
Yeah, so a lot of people, because automatically you'll say the word reflux and they say, oh yeah, acid reflux. I'm like, I didn't really say the word acid, because it's hard to define. There is no sort of bile barometer, bile, meter for the throat. There's no pepsin meter. And there are some heavy hitters in the field of otolaryngology and gastroenterology who are looking into that. But for now, I would even say to the point of maybe I would see, and again, this might sound like a strong advice, but a surgeon who can do something called fundoplication, where the pills aren't working, we think it's reflux. They can do a brief, minimally invasive procedure where they can actually tighten the sphincter at the bottom of the esophagus.
Yeah. And I always mention when I can local providers that do that. I know Dr. Lee Farber in Vassar does a lot of procedures like that. I'm sure there's some others that maybe I'm not mentioning.
Dr. Benetti.
Dr. Benetti as well.
And Rhinebeck does them. He's the bariatric surgeon.
Yep.
He also does those procedures I was alluding to before, but he's a fellowship-trained, minimally invasive surgeon in this department. So.
All right. They're coming on. That's next week's show, by the way. But
great.
So as part of the workup for postnasal drip, you a referral with a gastroenterologist.
Not always. I mean, look. Let me just be honest. If a person says yes, I have sinusitis, and you look at with a scope and do that. And by the way, the scope isn't scary or painful.
You're right.
And if they don't have polyps, I mean, if they have polyps, we treat them. And if they have, sinusitis clearly, then we can say, okay, yes, you probably have this mucus from your sinuses. But if the nasal exam is normal, I would strongly encourage people to have, what's called an upper endoscopy.
Okay. We actually have a caller about the subject. So what do I do, Dan? I just start asking the caller. They're on as well?
Yeah, they're on as well.
Okay. Good morning, caller.
Good morning. I have a chronic sinus condition. In fact, I was born with it, and I have a nasal drip, which is constant. And one thing that's been happening with me now, sometimes like when I clear my throat, and then I get this horrible taste in my mouth. I don't know if that has anything to do with my sinuses that would cause that.
Well, Dr. Corpus?
Yeah, so first of all, I would definitely dive into the whole history about being born with a chronic sinus problem. I would be very interested in that, not only from looking in the nose, but also using what they call CAT scan or CT scan, because that's the gold standard way to figure out what the problem is. People nowadays really don't have to live with a chronic sinus condition. I do procedures in my office that makes those go away. If not, there are some things I do in the operating room as well to make those go away. So that's point one. But point two, the taste you have is actually called acid brash, BRASH. And even though, again, it has this symptom, like a feeling like it's coming from the sinus, acid brash is that sort of, I don't know, I don't want to put words in your mouth, but like, like a metallic sort of like strange taste.
Okay, so what would you, what does that mean? Does that mean that it's more of a reflux problem?
I really can't tell on the phone. I don't think I would have to examine our caller. But from what she's saying, I would first have to clarify her sinus history.
Okay.
I have another question too. Is when I sneeze sometimes, I will get a glob of mucus from it.
Huh.
And what would cause that to happen?
Yeah, so inside of everybody, well, I shouldn't say everybody, almost everybody has these sinuses under our cheeks called the maxillary sinuses. And sometimes we can have deposits of mucus there, especially as people age, and especially in females. And the reason why is because without estrogen, after menopause, these bones that we have become smaller and the pockets get bigger. Does that make any sense?
Yeah. To me? Go on.
Yeah.
All right.
I'm just ready to hear if the caller has any follow-up.
What else can you done for a nasal drip? Is there anything?
What's the bread and butter recommendation we would give her before we go down the road of, more invasive testing? Should we try any empiric treatment on her first?
No. I used to do that. I did, but
All
nowadays it doesn't really make sense. I'm going to say something that might sound very self-serving, but I say, come and see me. I'm glad to help you. I do. I think maybe I'm a premature, old-fashioned guy, but I say history and physical goes very far.
There you go. That's what they taught us, by the way. They said everything starts with a good history and physical. We talked a lot about that in our show with the role of telemedicine and how it really is kind of trying to lower the standard of how we evaluate patients. Anyway, caller, did you have any other questions?
No.
Okay. Well, thanks for listening.
Thank you.
Yeah, thank you very much, and thanks for the information, and have a good day.
Okay.
Thank you.
So, Dr. Corpus, are you accepting most insurances at this point?
Well, as we transition to Albany, the answer is yes. I mean, I don't think there might be like a few that they don't accept, but in fact, it's going to expand greatly, which I'm happy with because, I think, Dr. Stamberg, you were in private practice at some point, right?
Right.
I don't know if you recall the battles and trying to get contracts with insurance.
Absolutely. I recall losing every battle.
And that's the thing, right? You got a whale and a minnow. And
that's right.
The minnow typically doesn't win.
I call it the gorillas.
So,
you call them the whales. I call them the gorillas. I said in order to
the gorilla in the room. Yep.
The gorillas in healthcare are the government, insurance companies, pharmaceutical companies, and then as a result of all this, the medical complexes have become gorillas as well. Nuvance, Albany Medical. That's in order to do business with the gorillas, you have to become a gorilla or at least become part of a gorilla. So you're joining a gorilla.
Yeah, I have to say, I don't know how many more in the Hudson Valley there are who are independent. And I was up until this week. And it's strength in numbers to one sense, but I know from a patient perspective, people do not like phone trees. People do not like, layers of bureaucracy to get in touch with their healthcare providers.
Right.
There's a lot to be said, but here's where we're at. And again, I'll say it another time. Patients need to have their voices heard, either through calling the insurance companies or their vote. Vote for ways that promote independence in practice of medicine.
Right. Hey, and there's the challenge because as I always say, I say this to patients sometimes. I say, as healthcare gets bigger, we have to prevent ourselves, and whether it's the doctor or the patient, from getting smaller. And patients do want that. They still want their relationship with their doctors or healthcare providers. So it's kind of up to us to maintain that as because that's really at the end of the day what's most valuable.
You absolutely. I couldn't have said it better, and I appreciate that. I mean, so long story short, yes, I'm accepting more insurances than I have in the past, which is wonderful. I've also got a great physician assistant named Lauren Dearlam. She takes care of most of the ear issues as well as allergy. We do allergy testing in my office. Okay. Again, we see patients of all ages. Allergies, as the caller described, sneezing is something we help out with, and we give shots to many patients once a week. They come in, and within a year or two, we get people immune to the allergies that bothered them. Again, we do office procedures to help out the ears, nose, and throat conditions they have. And sometimes people just like the peace of mind of knowing the symptom they have, where it's coming from, and everything is going to be all right.
Right. Hey, that's all, very, very exciting. By the way, earwax, is also the bane of existence for many people. Sometimes we clean it out in the primary care setting or the urgent care setting, but boy, sometimes that wax has been there for many years.
Yeah, we do. We have surgical equipment and techniques that, again, you hear the word surgery, it might create some anxiety for patients, but Lauren is our resident earwax specialist, and she's fantastic at doing it in a way that's, not painful. And sometimes it takes a couple of visits, Unfortunately, like you said, it's just so caked in there. We have to use maybe some medicines to loosen it up. A patient comes back after it's loose. We've got suction machines and microscopes and other tools to help people out.
And we have a couple minutes left, but Robin and I touched on the subject of hoarseness briefly, and I mentioned how important it is to have that evaluated, particularly if it's not improving and there's no other obvious explanation for it. But, unfortunately, the only way to really rule out cancer is to have somebody look at those vocal cords, and that's kind of you.
That's it. I do. I certainly, a senior citizen with a new hoarseness must have laryngoscopy, and there are guidelines written on it, but I wouldn't. It's a big deal to me, and thankfully there are patients who I see where it's something that is not, ominous and malignant, but rather things that can be helped with simple voice therapies or simple medicines. But it is a red flag and something that we can do. Again, I want to really get this point across that we can do this procedure called nasal endoscopy, laryngoscopy in the office. It takes around 1 minute of time. I always say this phrase. I say it's not going to be the worst day of your life. It might make you sneeze, it might tickle, but we can give you a diagnosis typically right in the office.
Sure. And Robin and I were also talking a little bit before you came on about the role of the ENT specialist in working up dizziness. she was talking about an ENG test. Is that something that is still being done?
That is correct. During the pandemic, we paused that because sometimes it makes people lose their meal. So we had that on pause, and we're going to restart doing that. And it's the ENG stands for nystagmography, which is basically looking at the way the eyes move under certain circumstances of moving the patient's head. Nowadays, we've accommodated what's called video nystagmography, which is really a computer-aided test. And so we use the acronym now V as in Victor, NG, N as in November, G.
Right.
So basically, but oftentimes we don't need to do that test. And again, I'm going to hammer this point of history and physical. So, some of the giants of the field of ear would say, you can make a diagnosis based upon history and physical in greater than 80% of patients. So, there's some classic, it lasts a few seconds, it happens, it feels like the room is spinning when I turn my head. Typically we talk about, the crystals of the inner ear in that sense. But, if a person has one side that feels full, or they hear their heartbeat in one side, or they can't hear in one side, those are, again, things that really need to be evaluated by the otolaryngologist.
Sure. Do you recommend for people who just have kind of more of a routine vertigo, the Epley maneuver?
It's interesting. I typically recommend physical therapy for that. I mean, we have these great nowadays doctors of physical therapy available to us who can do it in a very precise way. I must say, humbly, that there are some colleagues of mine who are also very good at it. I don't think that's one of my strengths, frankly.
Right.
To do the Epley maneuver in the office or to teach a person to do it, because I do also believe that if you do it on a patient that's normal, you might actually trigger this vertigo. So I refer to physical therapy.
Okay, good points. Robin, do you have any other questions for Dr. Courtbus?
What is the Epley maneuver? What
do you want to? Go ahead.
Yeah, sure. So the Epley maneuver is a certain way of moving the body and the head with the intention of moving the otoconia, which are the little rocks, if you will, inside of the inner ear to their proper position. And, the YouTube can show people what it looks like, and it's hard to describe on a phone call.
YouTube, yeah.
The maneuver.
Okay. Yeah. Right. You can look up videos for it on YouTube. I know Dr. Julio Vieira is a local neurologist. I know he's very fond of doing this for patients with success. But I guess I'll be honest. Last time I tried to assist a patient with this, I think her symptoms did worsen. So
yeah,
it has to be done right. So anyway,
let me just also say though that the Epley maneuver, I don't recommend it unless I'm very sure that it's just quote unquote just BPPV, which is benign positional paroxysmal vertigo. I think if a patient says I'm dizzy and I feel lightheaded, and you prescribe the Epley, that's probably not accurate.
Okay, right. So history and physical, like we said, we had a couple weeks ago. We had a Christine Ranke, a local physical therapist, and we also addressed the topic of going to physical therapy for help with vertigo. So and a bigger topic is just gait instability. Medicare is really kind of focused in on that, trying to prevent falls in the elderly. So it's kind of related. Yes. I think we covered it, and we're nearing the end here. But what's the phone number for your office?
It is 845-758-1456. 758-1456.
And also the patients listening, it's okay to bring this up with your primary care provider, because that's, we're the ones that might steer you in the right direction. But it sounds like a great therapy, and some of the other things you do in there. And good luck, by the way, with the Albany Association. I think it sounds great.
Thank you all. Thanks, Robin, and to the call screener, and to you, Dr. Stamberg, for allowing me to be part of this morning with you.
All right, great, and we'll have you back in the future. Okay.
I look forward to it. Thanks, guys. Right. Have a great week.
Have a great day. Thank you.
Bye-bye.
Thanks, Bob.
Very interesting stuff. Robin, do you think I should go?
Yes. Did you take down the number?
I have it just in case. Because one or two callers might call back asking for it.
Okay.
Yeah.
We didn't really go with it, but that he does that treatment where it kind of freezes the back of the throat, and one of the side. Remember when you were a kid and you had the Slurpee or whatever, you drank it too fast.
You can get a
got
brain
the
freeze.
Brain freeze. So that is a potential side effect of this procedure because it's that same area. He could explain the reflex more than I can, but there's a collection of nerves back there that when they're exposed to too much cold, they'll freeze up.
Oh, okay.
Yep. Interesting stuff he's doing there, and it's very exciting to be part of a residency program. And we talked a little bit about being part of a gorilla. That's the way it is. So when I was in private practice, a company would say, "Here you go. Here's your contract. We're going to pay 80% of Medicare. Generally, Medicare is the standard." And you go, "Oh, but I want at least 100% of Medicare." And they go, "Well, never mind. We'll give us that contract back, and you won't see our patients." So eventually that doctor winds up part of a big entity that now can negotiate with those companies, and they get 120, 130% of Medicare. The irony, of course, it's one of the many things that makes the kind of cost go up. This if they just gave a guy like me when I was in private practice, 105% of Medicare, I would have been like, okay, sounds good.
Right. When patients call and their insurance is not on par with our practice,
right?
They don't understand. They're like, what do you mean? You're not on par. You don't participate with this insurance. I was like, it's kind of like applying to college. It's like you've got to apply to this company. If they accept you, they accept you. If they don't, they don't. It's you. You don't have much bargaining room.
No.
They either decide that you're worth it for them and their insurance, or you're not. So it's tough.
And there's one local company that has a Medicare product that really does a pretty poor job of recruiting a network for the patients. A lot of local doctors, choose not to accept it. So a guy like me says, well, go to see Dr. So-and-so. Well, Dr. So-and-so's not on the plan. Then it becomes kind of this whack-a-mole. Well, who is on the plan, And actually, I ask the patient for assistance a lot. You need to check with your plan and find out who's available.
Right.
It can be very frustrating for the patient. So whenever you sign up for a Medicare Advantage plan, I always say to patients, make sure you understand, you can figure out what the advantage is. And if you can't, don't sign up for it. And also, don't let them change your doctor. That's happened too. They'll, Dr. So-and-so, he's on the plan. Next thing you know it. I had a patient, long-term elderly woman, patient of mine who had to change doctors recently. She had signed up with the assistance of her son. They were told that I was on the plan. And guess what? Not on the plan. Anyway, Robin, look at what time it is.
Another show. Another
show.
Successful show. Thank you so much to Dr. Michael Corpus. What's his phone number again, Eric?
His number is 758-1456. Next week's show, we have representatives of the bariatric program over at Northern Dutchess, so it does kind of cross over into what we talked about today.
Yeah, that was very interesting.
Yeah, and I think it was a great show.
Have a wonderful day, everyone.
Okay. Robin, you too, and thanks, Dan. And happy birthday, Lawrence.
Happy birthday, Lawrence.
All right, take care.
Thank you, Dr. Eric Stamberg and Robin Baker. Thank you for bringing us this magnificent Medical Monday. And our last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. And it is Monday, June 7th. 72 degrees right now here in Uptown Kingston. Thank you for sharing the morning with us and participating in Kingston Community Radio, AM 920 and 92.5 FM WGHQ, and our live streaming on mykcr.org. Talk radio at its best, inspired discussions of, by, and for the community. And we invite you to be with us tomorrow morning at 7 a.m. Until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you back to Magic 92.5.
We were running against the wind.